What I'm going to talk about, I think, is maybe to some of you kind of contrary to where you think we should be going. I was ER director for 25 years in an ER in Los Angeles. I got a clinical appointment at USC, small intimate rural residency there in Los Angeles, that has cranked out more ER doctors than any residency in the country. Right now they have 68 house staff in emergency medicine, small, intimate little place. So here's what I kind of view as what's happening in one sphere of emergency medicine. There's money going out the door, where it's going down into the black hole, it's being sucked out. And we have an ability to intervene in this, should we have a mindset that says, look what we found, let's kind of fix this kind of thing. What I want to talk about is not the big shark. ER is the big shark. It is the credible big dog of emergency medicine. But I want to talk about the little fish that swim with the big shark, the little fish that live off of the big shark, the little fish that live off the droppings of the big shark, and they're nice and fat, if you know. They're very happy kind of thing up there. But I'm a little concerned about them. Why do people want to go to emergency departments? You are the most credible provider of health care in the community, by and large, no doubt about it. Look at the size of that beautiful building they have there, kind of thing. We know that they check out the doctors to make sure they're not felons. They do PR and peer review, those kinds of things. It's a very credible kind of place. They have every piece of equipment you can think of. It's a state-of-the-art CAT scan machine. They got 5 of them. And so if I get into some kind of medical problem, I want to go to this place. They got the best of everything, that's for sure. Why wouldn't I go to this place? Because it's perceived that you will have to wait when you go. And people say, well, yeah, I understand that, but if I have a heart attack, I want to go to that place. I have something more minor. Well, I do know that there is this wait. We have a reputation, a national reputation for making people wait. As far as I know, emergency medicine and the Department of Motor Vehicles are the only 2 businesses that have a reputation for making people wait. And I think that it's embarrassing that we have not been able to address this very effectively. So we have long waiting times generally. I know everybody's working to get a door-to-provider times down to a half hour or less, and I think that's a really great initiative. And I think it's about time that the Joint Commission took a look at things like ER processes rather than the head circumferences of the children that come in there. That maybe measuring head circumference is important now, given those mosquitoes. But in any case, it wasn't before. So the charges are high. The waits can be long, and patient satisfaction can be an issue. I'd like to make this as factual as possible. So here's the story. 80% of emergency departments are discharged. That's the national average. 80% go home, 20% get admitted. And you're the big dog for admission. 60, 70% of the hospital patients who are admitted came through the ER. They appreciate that. That's great, thank you. But 80% go home. Now, there's always this conversation about, well, how many of those people really, really in the emergency department are sick and need to be there kind of thing? And it really depends on who you ask. Like this first, if you want to be a student of this topic, there's 2 papers written in the New England Journal, the July 23rd issue. Get those 2 papers. It goes into all of the details about how your crowding is going to be relieved. But in any case, this New England Journal paper says between 1 in 8 and 1 in 4 people can be seen in a retail clinic or an urgent care center, and that if they we're talking about $4+ billion. So that's one analysis. National Hospital Ambulatory Medical Care Survey says between 33 and 50% of ED patients are non-urgent. Well, if they're non-urgent, that automatically says they can go to the urgent care center. In fact, the urgent care center ought to be called the non-urgent care center because all these people can go there. The third thing is the New England Health Institute says 56% of patients are totally avoidable. Now, I'm not exactly quite sure how they define totally avoidable kind of thing, but the numbers basically go up in terms of how people who can be treated in other venues other than the emergency department. And lastly, what does ACEP have to say about it? Well, ACEP says 92% of ED visits are from very sick patients who need to be seen within 1 minute to 2 hours. What a joke. What a joke. You know that that's not correct. 92%, I get in 1 minute, I got to see this person, or 2 hours, or this snotty-nosed kid basically is going to get better. Yeah, we have to intervene in these cases before they get better, since so many have some self-limiting disorders. You don't have them waiting in the ER, and then I'm all better now. It's generally believed that the quality of the emergency department is clearly better than the quality delivered in any other place because, well, they got all this stuff there. They got the best doctors. They got the best everything. So the quality's got to be great. Here's a study. This, and it's not the only kind of study, I can tell you that. And it's old. It was done by RAND, these think tank people in Santa Monica. And basically they looked at paid from a large insurance company in Minnesota, paid visits for 3 disorders: otitis media, pharyngitis, and UTI. Otitis, all 3 of these are zero-nothing diseases. And they looked at what was the paid amounts to a convenience clinic like CVS, doctor's office, urgent care center, emergency department. So those 3-nothing visits going into those 4 venues. There was $100 paid into the CVS type clinic, $160 in the emergency to the doctor's office, $160 to an urgent care center, and $570 to the emergency department for the same nothing diagnoses. So the emergency department was between 3 and 5 times more expensive than the other places. But of course, we know the quality is much better in the emergency department. Or is it? So 12 standardized measures of quality regarding the treatment of these 3 disorders, and the emergency department finished dead last. So we're slow, expensive, and our quality, worthy of challenge. I mean, I want to wear the white hats and say how great we are all the time, but I think that the purpose of this 25 or 30 minutes is to kick you in the shins and tell you that there's great opportunities that we're letting just leave the building because of certain premises. Here's some prices. I think the prices in emergency departments really are kind of, most of you have never seen an ER bill. Many of you have not seen an ER bill. I think ER bills should be sent to you every week to see what bills you're generating when a person comes into the hospital. So here's a large survey, a sample of 8,000 visits, and the largest group from which that sample came was like about 5 million visits. It's old, 2006 to 2008. Mean and median. Mean, the difference between median and median. Mean is average. Median means half the charges are below it, half the charges are above this number. Well, if you look at the mean, a URI is $1,100, and this is like 6-7 years ago. An open extremity wound is $1,600. And bottom line is, you're not getting out of the emergency department for the most minor of stuff that you have, because this is the top 10 complaints, for less than $1,500, which is the CVS will be able to beat these prices by tenfold in terms of what you will see what they get paid. Now, there are some businesses that talk about getting things done quickly. You would think that the 2 businesses where you would do things quickly is in the emergency department, because I'm sick, I have a headache, I'm throwing up, I got a pain, I got a cut here. Come on, let's move, guys, kind of thing. Oh yeah. We have a nice big waiting room here, big saltwater fish tank. You'll love it. But the fact of the matter is they want to see the treating person pronto. So our business should do that. These businesses make it very clear, we're going to change your oil in 10 minutes. We're quick, speedy lube, express services, quick car lube. 10 minutes, we're in and out. Do you think we have anything like that? This is us making excuses. I know you think we're slow, and we are slow, but we're going to respond to that by putting up all of these billboards to say we're not as slow as you think. This is embarrassing. I like some of these. Faster boo-boo relief. That's one place. Get home before others get in. You know, they have these meters up there. This is our waiting time. Those meters probably never change. You know, it looks like it changes, but they never change. Why wait? You know, all of these. What other business does this? What other business does? Is this not an embarrassment that we do this? I think it's absolutely nutty. And then you have this. Have you seen this thing where you can? This model is called InQuicker, and it started out where patients would pay some amount of money, $15 or something like that, and they would save a space for them in the line of the emergency department. How they did that with HIPAA, with EMTALA, I don't know, but they got around it somehow. So you, on the internet, you make a space, and they'll give you a call. Mr. Smith, we'll be able to see you in about 15 minutes. So the idea is you're sitting at home, not in those plastic chairs that they have in the emergency department. You're sitting at home in your nice big chair waiting to be called in. If you could read the small stuff in the bottom left there, it says something about facilitating your place in line. Well, the fundamental question is, why is there a line? We're not supposed to have a line in the emergency department kind of thing. Lines are for, you know, we're more discretionary places like the DMV. They can have a line. You can have a line for, not for healthcare, for certainly, but they've come up with a whole frickin' industry to deal with our screw-ups. I think that this happened 40 years ago. This guy was walking on the moon 40 years ago. And 40 years ago, they were still bellyaching about holding patients in the emergency department. There's too many people in there in the waiting room to be seen. They're all here with colds and they don't need to be here, damn it. And they're just taking advantage of us. And the waiting room is packed, and can't we fix that? And 40 years ago, they did this. And 40 years ago, we have not been able to fix this since then. The changes that we've made have been modest at best. I know that there's an effort to do it, but a lot of you here have ERs that are quite dysfunctional, or you wouldn't be here. Now, during this conference, there's been a lot of talk about how to fix stuff. And Sherry, in particular, gives these long litanies of ways that things can be fixed. However, and I'm not going to go through this list because it's been done before. But I think one of the things on the list that I don't see in any other people's list is number one. The CEO needs to want to make your ER better. And if the CEO is not interested in making your ER better, then it's not going to happen because this is top down. Top down works, bottom up, painful, bottom up. So you have to have a CEO who's enlightened, who understands that more patients experience your hospital through the back door with the bulletproof glass and the plastic chairs than come through the front door with the big donor wall up there and the nice padded chairs. And the smart ones will understand that, and I don't really understand why they don't get with the program, because they are the ones that can fix this. They are the ones who can deal with holding admitted patients in the emergency department, because frankly, it's easy. Your job is to basically assess all of these patients and see how they're doing and decide after treatment and testing which ones need to come into the hospital and which ones don't. And with some time, you can say, on average, we're going to admit X patients per day at our hospital on this day or that day or whatever. And so on the other side of the wall, on the inpatient side's job is to create the space to put these 20 patients that you know are going to be admitted into that hospital. They have an obligation, and they basically have turned their back on that obligation. So what you need is you need a physician that is well regarded by the medical staff, who has the authority to go around and say, Frank, does your patient really need to be there, or we're going to be needing that bed tomorrow? Their job is to create the capacity to see the patients that you are creating in terms of admissions. And if they don't do that, then you're going to hold all these admissions, and they're going to get dribbled in as patients come out. But a more active process, and those of you who have an active process got to be. Nurses are okay, but doctors are much more inclined to listen to doctors and say, Frank, come on, give me a favor here. Get this patient out. Let's see what we can do. We need the bed. We're going to need the bed tomorrow for our ER admissions. I think that needs to be done. I think that needs to be done routinely. The CEO needs to fund that person for doing that. That person needs to be medically credible so that the doctors are willing to listen to him. It can't be necessarily, and if it's generated from the medical staff, the organized medical staff has created this position of helping move people out who need to be moved out more quickly. Because, you know, one of the problems with Medicare, as an example, is the longer the patient's in the hospital, the more doctors make. And the longer the patient's in the hospital, the less the hospitals make. So there's this constant tension about length of stay. And the fact of the matter is that most hospitals are not doing very well on length of stay. Some are, but most aren't, which means that there's room for improvement in getting these people through the process. The doctors need to be motivated. The doctors need to have a champion to basically kind of get this process done. And if you don't have that, you're coming up against a wall of, well, we'll get these patients out when we get these patients out. But there is relief in sight of all this overcrowding and all this, you know, and the unwashed masses that you're dealing with in the ER. No problem. Here's one option, retail clinics. So the one on the left is Walmart. Well, the one in the center is CVS, which is the big dog right now. One on the bottom was Target. Target stuff was bought by CVS. And I think the one on the right is Kroger. Little data on this. First of all, go back to those two articles, a lot of information. In any case, there's about 1,900 of these retail clinics out there, and CVS is moving fast. They got 1,000 now, they're gonna have 1,500 by the end of 2017. Now, when you look at capacity, CVS, Walgreens, and Kroger altogether have 20,000 stores, 20,000 stores. 8% of those stores have these clinics inside of them, rendering 2% of primary care. 8%. So the capacity to expand that is huge. And then there's the sleeping giant, Walmart. Walmart's got 4,500 stores in this country. Virtually every one of them has a pharmacy in the store already to facilitate, you know, making their. They've started 17. They're way behind, but they have the capacity to blow past a lot of these others. They are now providing, in this 17 test stores, medical care for their employees at $4 a visit. $4 a visit. Non-employee visits are $40. They're interested in not only your urgent care kinds of things, but they're interested in your cholesterol, blood sugar, blood pressure as well. So these guys have an expanded view of what urgent care centers can do. If these guys wake up, you know, you can see Walmart, biggest retailer in the country. If they see the opportunity here, it's going to happen. So that's the convenience clinics. Then we move over to the urgent care clinics. There's about 9,300 of them. They're building 300 to 600 a year. I know some people who have a cluster of these things, and they get bothered weekly by venture capitalists who want to buy up these things because they think that these things are going to be printing presses for money with time. And look at the numbers that they generate. This is information from the Urgent Care Association of America. This is a survey from 2012. They were bringing in $105 to $135 net. So that was like the profit. Profit is $100, $135. Look at a couple of the bullets under there, what the association has said in their website. Number one, 95% of the members call or email the patients from who they had just seen. Now, that doesn't happen in the ER. We're way too busy. Can't you see that we're busy? We'll get to you when we can. But only a small number of ERs go through this effort to make it clear. It's just a courtesy kind of thing. Yeah, you might find out if they're not doing better and have them come back, but they're just so pleased that you made the effort to call. What is their throughput? 84% of them saw patients within an hour or less. An hour or less. What's your throughput time for a discharged patient? If it's 3.5 hours, you're considered to be, that's terrific. If it's 2.5 hours, wonderful. They're at 1 hour for a patient. They see 4 patients an hour. You see 2.5. So, and 2.5 is considered in some places to be fairly aggressive. They're seeing 4. and are seeing 50 patients a day. So bottom line is they're making money on the droppings of the ER. The ER could be seeing these patients if we created the same kind of environment, called the patients back, nice environment, no blood, no screaming, no nothing. Here's the urgent care part of the emergency department, and so we've caught that part of the population that these guys are making a living on. These are making a good living on them, and they're expanding all the time. So if they can live on your droppings, then why don't you live on your droppings? I like this one. Dr. Phil is hooked up with Google. Pretty powerful combination. Well, at least Google is. Basically, the idea here is that you, on your telephone, basically try to get a hold of a doctor to have a consultation with that doctor. And you see on the telephone on the right, the patient's on the top, the doctor's on the bottom. You may not be able to read that stuff along the bottom. It says, stop the guessing. Self-diagnosis never ends well. It doesn't. And doctors online and by phone are available 24 hours a day. And what happened is that in 2013, he started this thing up with Google, and they have 1,400 board-certified doctors who are willing to participate in this endeavor. And they've had several million downloads of people who are interested in participating. $40 for a video consult. I like this. Psych problem, we have to charge more because, it's just a hassle to talk about your depression. Thank you very much. They say that they handle 95% of the calls and don't need to refer. They refer only 5%. I find that very, very difficult. Who uses telemedicine? Single moms. Basically, it's about kids. Married mom, that's okay. Febrile, snotty-nosed kid, they're going to go to work. Can I go to work? They won't take the kid daycare if the kid's sick. So this is happening for the moms. There's big money in this, and as a reflection of the big money, Teladoc lost a $1.5 million contract, and it only represented 3.6% of its business. So we're talking about $30 million at least there. I like the last number. It says in 2015, 1 million people will have a webcam physician visit. 1 million people. $40, I don't think that's very bad. House calls. This is, I like the bottom one, the bottom right. The doctor and the child both look like they just got out of jail. They're wearing the same shirt. I think that they faked this picture, to tell you the truth. But in any case, they come through your house, so wonderful, and check your belly out on your couch, and console you in your bed while your child's looking on, saying, "Oh, mommy, oh, mommy." House calls, basically, a couple of them. This one is, the first one is LA-based. This started by a nephrologist and her husband, and basically they come to you with a tech who brings on this high-tech instrumentation, like an otoscope. Well, this otoscope takes a picture, so you can say, "Look, see how red it is? There's your problem." Or no, it looks okay, Mom. And they have the blood test that you can do. What is that? ISAT stuff. They can do all of that if they need to. Look at this flat fee, $100 basically, between 8 and 8, and they'll pick up a prescription for you if they need it. Of course, you're going to be getting prescription for bronchitis. Bronchitis. You'll be getting a prescription for bronchitis. Everybody will have bronchitis. I like number 2. This one is founded by one of the guys who created Uber. This is going to be medical Uber. $50 for the first visit. $50, man. I was, you know what I was thinking of doing? I was thinking of calling one of these up right from this stage, and see how long they came on, and to say, like, I wonder if it says belly pain. Can you come check us, please? To see how quickly they would get here. But they're popping up all over regionally to come to your house. And then we have freestanding ERs, and Tim is absolutely the expert on this. But there is some downside of this, and you all are aware of it. This is big money. Adeptus Health is looking at owning 63 of these, and their revenues are there. But are they in the rural areas, the underserved areas, or the low-income areas? Tim was very frank and said, no, we don't build these things in those areas. Why would we? We build them where the hospitals are, in the affluent areas, and so that makes perfect sense. But there's this issue of the charges and the confusion of the ER. Is this an ER with an urgent care? And there are 4 TV exposés of sorts where people basically raised holy hell with the TV station about stuff like one kid got 4 stitches in his thumb and a DT shot and was charged $4,200. Sounds reasonable. That's about $1,000 a stitch. There's this Denver News. These are all recent too. They had multiple patients. One of the patients had a bill for $8,200 for a CT of a chest and abdomen. So there are some challenges, and I think that Tim was pretty frank in discussing what these challenges are. You can be on either side of the fence on these, to be very candid. So in conclusions, I basically think that you're going to get 20% of the patients to be admitted. You don't need to be nice to them. You don't need to have patient satisfaction. It doesn't matter. They're coming by ambulance. They're sick. They're coming in. It's the 80%, the discretionary 80% that can go, I'll go to this place, or I'll go to that place, or I'll go to this place. And those are the ones that I think that you have a lot of control over, but other people are saying, oh, you can't handle it, you got a problem with it, we'll take care of it for you. We'll just take care of all this low-hanging fruit. We'll take these paying patients away. Thank you very much. The CEOs can fix this, and that we just need to acknowledge how important. We could not survive if we only had the 20% of patients who admitted. These 80% are fundamental to the business of the emergency department. And if you let people take them away, then you will have more and more just admitted patients. Your volume will go down because they represent 80% of the people who walk in your door. So my sense is that you need an initiative out there to say, we're going to cultivate these patients. We're going to make the call. We're going to charge them prices that are fair. We are going to make it clear that we want you here and that you're not in the way. The ERs, they've got this attitude often. Can't you see we're busy? We'll get to you when we can, kind of thing. That's not with the attitude of the urgent care centers or CVS or Tim's freestanding urgent care centers. And I think one of the things that we haven't talked about particularly is the use of the right people. We need to use PAs and NPs. We need scribes. Those doctors, I don't know about you, but we had scribes. We started off as scribes, and we had scribes way before it was fashionable. And we had all old doctors. Old doctors knew tricks. But when we hired these scribes, it was kind of like, they got used to it. It was kind of cool because they're not really scribes. They're personal assistants. And they would get your lab studies to you and put the x-rays up on the view board and those kinds of things. And one of our doctors got so addicted to his scribe that when the scribe would call in sick, this guy would be in the corner sucking his thumb saying, oh God, I have to do this shift without a scribe. And PAs and NPs, they're in, and the fact is they're exploding. There's more and more of these schools generating. There's 100,000 PAs, there's 100,000 NPs, and there are tons of new schools for cranking out NPs, PAs in particular. So we got to use the right ones so that bottom line, we get this. This is the goal. This is the goal. To have a free-floating brain in the department, just oozing around the department, just talking to the patients. It doesn't do any order entry. It doesn't touch a computer screen. It doesn't pull up any X-rays. It doesn't. All labs are provided. It doesn't do anything except think about the patients. How many patients could a doctor see and do a good job on if it was just free, facilitated, unencumbered, medical brains. That's what we're looking for, I think. All right, thank you.